Thank you, Ashay, and the organizing committee for organizing this wonderful conference. Good workshop here. A lot to learn from here. I'll be talking on knee Scopy and BTB harvest. There will be some repetition definitely, but since Ashay has said ki you should, repetition is good. So I'll just go through a diagnostic round, only a video. Yeah. So first, as Dr. Sarthak has already said, and Dr. Neha and Dr. Tejas have already said about the anatomical landmarking. So first, most important thing is marking the anatomical landmarks. First of all, marking the tubercle. Then we mark patellar tendon and the patella. So I generally do surgery in hanging position. So here comes the anterolateral edge of the patella, anterolateral portal. Then you mark the anteromedial portal. Generally, I have my anteromedial portal slightly higher than anterolateral portal. So we will see how all the 6 portals are made. Then marking here for the superolateral portal and superomedial portal. So mark the patella, and 1.5 centimeters above that will be superolateral portal. So once we have marked all the 4 portals here, then we see, yeah. So then we see and for the posterior portals. So these are the 4 portals that will make, and the one posterolateral portal and one posteromedial portal. So as we have seen earlier also, the best way to see posterolateral portal and posteromedial portal is by transillumination test. So here we do anatomical landmarks. We first mark the fibula, and we palpate for the nerve, common peroneal nerve we have marked here. Then that's the biceps tendon, and you also mark for the inferior, palpate for the inferior part of TFL. So you palpate that, and in between the two, so your posterolateral portal will be anterior to biceps tendon. In coming to the medial side, this is the joint line, mark for the distal femur. It's running slow. Yeah. Here comes our posteromedial portal. Once you have done anatomical landmarks, okay, then I usually make a vertical portal. It's personal choice. You can make up a vertical portal or a horizontal portal. This video is running in batches. Okay. It's running and slowly. Yeah, once you go in the suprapatellar pouch, there's the normal diagnostic round. Yeah, so then you see the patella. Once you are there, I generally go over the medial femoral condyle, then you come down. Yeah, so once you see the medial femoral condyle, come down. Okay, so from here you start going into the, once you are there in the notch, then you go in the medial compartment. Yeah, now it's working well. Once you go in the medial compartment, see for the medial meniscus. From here itself, you can go into the posteromedial recess, posteromedial space you can go. And you can assess for if there is any ramp lesion or the posterior lesion. So here we'll see how to make a posteromedial portal. So once we have marked, it's the point is 1 centimeter posterior to the joint line. So you see a needle coming out there, and you can adjust after once you have seen with your needle. So if you think that it's slightly lower down, you can adjust it slightly higher, or you can change the position. This is the transillumination test, where you dim your lights, external lights, and then you can see your posteromedial portal. and then you can come through the posteromedial portal, the point where you have marked, and come into the joint, and then you can see. So this is the best way if you have issues with the posteromedial portal using a transillumination test. Coming to the lateral joint, similarly you can assess in the posterolateral space. So once you are there in the posterolateral compartment, this is the posterolateral space. The point from where we have marked, you can enter, place a needle, and see for your posterolateral portal. Similarly, as we have done with the posteromedial portal, we can do this posterolateral portal with a transillumination test. You dim your lights, figure of 8 position, and then you can clearly see where you have to go. You can see the veins also here, so you can be slightly away from the veins. So once you see this, yeah, so you can place your needle, and then you can see the needle coming from the posterolateral recess. Once then your anteromedial portal, once you have made your anteromedial portal, place the needle, check, verify whether its direction is proper, and then place a portal out there. I try to have a smaller portal, dilate it with a scissor or an artery forceps, and then your probing comes. So when you are doing a diagnostic round, always try to see from both the portals. Anterolateral portal, as your diagnostic round is not complete until unless you see it from both the portals. So here the viewing portal is the lateral portal. You are probing the meniscus, probe the superior surface, inferior surface, see all the things on the medial side, cartilage, meniscus, then come in the notch, then in the lateral compartment, palpate for the meniscus, superior surface, inferior surface, see for whether if there is any tear. Try to keep the camera in anatomical position all the time. You can see the popliteus tendon there. That's the popliteal hiatus. You can see. So this completes our the lateral compartment. Also see for the cartilage on the lateral femoral condyle and lateral tibial condyle. Once you complete your lateral part, then we can go again in the suprapatellar pouch and see for our supramedial and superolateral portals. So once you are there, the point where we have marked our superomedial portal, yeah, you palpate it with finger. You can see the movement on Scopy. Place the needle there. Yeah, you can see. Here comes your needle. So this on the superomedial and superolateral portals, you can adjust and place wherever you exactly want to. So you have to locate that with the needle, and you can change the position depending upon what your procedure you want to do from there. And this goes the superomedial. Place a needle out there. So this is important if you are doing synovectomy and all the procedures. So you need to know all the 6 portals. So yeah, here comes your needle, and from there you can make a portal. You can place a scope there, or you can place an instrument out there. So when your scope is in the lateral portal, anterolateral portal, from there itself you can go down into the lateral gutter. Yeah, after you have done this, you go to the lateral gutter. You can go down till you can even see the good popliteus tendon out there. You can see the popliteus tendon there. This is the popliteus tendon. That's the popliteus hiatus of meniscus which we are seeing. So that's the popliteus tendon. And yeah. So this completes our complete diagnostic round, and you can see all the 6 portals you can make with this. Okay, so now coming with the other topic of BTB graft harvest. We have already discussed, Shushruta has discussed various graft options. So coming to the BTB graft harvest, when you are harvesting the graft, first of all thing is you assess the length of the graft, the tendinous portion of graft that you are getting. I think this is the only graft where you can calculate the length before itself. So you calculate the length, assess the length, what you will be getting. So you can calculate on your MRI itself. Okay. So this was a case of revision ACL. You can see a pivot shift. So here there are various type of incision that are used for a BTB harvest. Commonly used an oblique type of incision. You can also use paramedian incision. Generally the large incision, central vertical incisions are not used. You can take oblique incision, and basically you have to work through a mobile window. You can, when you place the knee in the extension, you can harvest the patellar part of the graft, and in flexion you can harvest the tibial part of the graft. So you have to make it a mobile window of that skin incision where you can harvest the graft. So the other thing is you have to be conscious there about the nerve damage for the paresthesia over there. So you try to take oblique incision or small paramedial incision rather than, sorry. Yeah. So once you have placed this or incision, so once you have placed the incision, you have to 4 retractors can be placed. We usually take 10 millimeter of the graft tendinous portion. While you are incising this graft, take the knee to 90 degree of flexion. Whole of the tendon should be taut, so that you cut along the line of those fibers. So once you have cut the tendon 10 mm, then you start cutting the bony part. So you have to cut this graft will be around 20 millimeters of length and 10 millimeters of the width. So you have to cut it on the medial side, lateral side, distally. The angle, generally what we want is a trapezoidal type of graft. So you cut on the medial side with a slight angulation, about 60 degree of angulation. You are not able to assess that. So slightly angulated on the medial and lateral side. The other thing that we do on the tibial part of graft is that we try to harvest a tongue of the tibia, addition to the tibial bone plug. The advantage of the tibial tongue that we can get is it helps us in if there is a graft tunnel mismatch, it helps us in reducing that. So once you have done that, here we are going on the medial lateral side, and then this is the part of tibia bone above the insertion of tendon. So here you can get at least 15 to 20 millimeter of length also, additional length that forms the tongue of the your tibial part. Once you have cut it from all the 4 sides, then you just have to use an osteotome to just take the graft out. Then you place the knee in extension, and you might have seen these 2 holes what I am showing there. So these are the 2 pre-drilled holes that we have already made with 2 millimeter of K-wire. This is placed in full extension. You give a traction on the inferior part of the graft, bring that into the mobile window and cut it from superior, inferior, medial side you have to cut, lateral side and the upper side, and then on the inferior side you have to cut, and then we are able to harvest the graft. Once your graft is out, I try to get the bites, suture bites, circumferential bites. You can see here through the 2 drill holes that we have made. Yeah, so this is the final graft that you get. Yeah, so you have 2 sutures placed circumferentially. The tongue which you can see here, this helps you in minimizing the graft tunnel mismatch, and that one is the patellar part of the graft. So this completes our harvest of the graft. Thank you.